It's really amazing to see, the progress that's being made in lung cancer. A few colleagues and I just recently wrote a review article that was in the January issue of the journal Nature, the Biology and Management of Lung Cancer, where we have a timeline over the last 20 years. And it strikes me that 20 years ago, when I was a fellow, all we had was chemotherapy, and we actually were quite excited because it was new chemotherapy, better tolerated chemotherapy. But now we have targeted therapy, we have immunotherapy, let's not forget radiation in selected patients, even with metastatic disease, to sort of stimulate cytokines and perhaps abscopal effects. And all these, and of course supportive care, and how to integrate all this together really is the art of medicine. The key thing is quality of life and patient care. Even if we don't cure the patient, we want to make sure that their quality of life and their toxicity management is as best possible. And we're learning now how to deal with the toxicities of these different agents. So certainly immunotherapy has toxicities. Keep in mind there are some patients who can't get immunotherapy still. Someone who already has an autoimmune disease, a rheumatoid arthritis, multiple sclerosis, where I guess you could use it if you really had nothing else to do, but you risk activating an already present autoimmune process and making that work. So in those patients, you might go right to the chemotherapy or the chemotherapy ramucirumab combination. Then, of course, there are patients who are getting immunotherapy and aren't benefiting, and of course, they're ones you might go to and switch to the combination. And then, of course, we're getting better at dealing with the chemotherapy combinations as well. I think nowadays, I think we are able to treat patients, more effectively with docetaxel. And some patients actually do quite well with it. Some patients do have neutropenia, do have edema and fatigue and other problems. But I think, symptom management has become such an important part of oncology. It wasn't long ago that we had data that showed, and that still show, that palliative care early on in patients with metastatic disease improves survival. I know at the Yale clinics, Smile Cancer Hospital where I work, when someone comes in with metastatic disease, certainly in someone like this who would have had symptoms, we would have had this patient see someone from the supportive palliative care group right away, because to manage the side effects. So I think managing side effects is important. Certainly you don't want to leave anything on the table. It would be great if immunotherapy worked for everyone. It does not. I certainly am a believer in trying to get those immunotherapy drugs as quickly as possible to patients. So even in PD-L1 0 patients, I'm still using immunotherapy up front. And I think more and more data are going to emerge so that almost everyone will get immunotherapy up front. But then you're sitting in the clinic and someone's resistant to immunotherapy. So why are they resistant? There are so many clinical trials. There are 500, 1,000 different drugs and different combinations that we can test. But right now it's all that, clinical trials. But that's not what you have when you're sitting in your office in a community practice in rural Chicago. You need something that day while you're looking for the trial, and that's where I think we need to keep in mind the docetaxel or the docetaxel with ramucirumab. Frankly, I don't think you add too much risk by adding the two drugs. It's an approved standard of care. It's a combination that's been shown to have activity, even in patients who have progressed on frontline therapy, as we're seeing in some of the updated analyses just presented recently. So that's where you would use that combination as we continue to probe patients and say, why was the immune system resistant? Are there regulatory cells? Is there a lack of T cells, a lack of inflammation? Are there other things that we can do? And we're seeing that across all tumor types right now, figuring out how to best target the immune microenvironment. But it's important as a clinician to have all these tools available to you, and you need to have them right then and there when you're seeing these patients, because a small response can have a big effect on symptoms, and certainly keep that patient going as you look for the next trial or the next combination. And that's why it's so important to be aware of the most updated data.